Antepartum Fetal Surveillance right now. So yes, tell the mother to see for the fetal movement count. This is known as the daily fetal movement count. You tell the mother to lie down in a left lateral position or a right lateral position after having a meal, and then count the movements after every major meal. So if there are more than 10 movements in the 12 waking hours, then the baby is healthy. Then we can also do the non-stress test. The non-stress test is the sympathetic versus parasympathetic system well-being. This is established, the sympathetic and the parasympathetic system in a fetus is established at 28 weeks. But generally 32 weeks onwards, we do the non-stress test. So what is the fundamental behind this test? The fundamental is that with the movement, the heart rate will increase. Like wherever you're sitting, your heart rate would be now 70, 72. Now if you go out, take a ride in the garden and come back, your movement will increase your pulse rate also, and when you come back, it'll come back to normal when you're resting again. So with your movement, your pulse rate increases. Same principle I'm putting up in a baby also. I have put a probe on the mother's tummy, and that is catching the fetal heart rate. This Doppler is catching the fetal heart rate, and it is going at, let's say, 130, and suddenly the baby moves in the tummy. The baby moves in the tummy, the heart rate would increase. So the increase in the heart rate with the fetal movement is a desired thing, and when the movement reduces, then the heart rate should come back to normal. So that is what is a non-stress test. So if I draw it and show you, let's see. The heart rate of a baby is normally 120 to 160, and suppose it is at 130 right now. The baseline is at 130. Now there was a fetal movement here. So with the fetal movement, the heart rate should increase, and then it should come down. Then it should increase again, and then come down again. So with the fetal movement, the heart rate should increase. So see, from 130 it's gone to almost 150 here. Yes, the rise in the heart rate should be at least more than 15 beats. 15 beats I'm writing, 15 beats from the baseline, and this rise should last for more than 15 seconds and should come at least twice. More than twice is better. It should be at least twice in a 20-minute observation time. So yes, 2 or more accelerations of more than 15 beats from the baseline lasting for at least 15 seconds, and this should happen at least twice in a 20-minute observation time, and that is what is known as a reactive non-stress test. What is the meaning of a reactive non-stress test? That the chance of intrauterine death is less than 1% in the following 1 week. If the NST is reactive, that means the baby is healthy enough, and we are rest assured that the reactive NST, there is a 99% chance that the baby will stay alive for that next 1 week. The chance of intrauterine death is less than 1% in that following 1 week. Alright, now how frequently we do the NST? That is also a very common question. We should do it at least weekly. Weekly NST after 32 weeks for all women who are pregnant. All women who are in the antenatal OPD. Now, it should be done bi-weekly if there is a high-risk pregnancy like the ones I told you. And it should be done once in 48 hours, once in 2 days for controlled diabetes in pregnancy and severe hypertension. And you know what? It should be done daily for uncontrolled diabetes mellitus in pregnancy. So yes, There is only one condition which scares us so severely that we will do the NST daily when there is uncontrolled diabetes mellitus. Alright, otherwise weekly is enough and bi-weekly for all the other high-risk pregnancies. So that's the non-stress test. Now, what is the biophysical profile? The biophysical profile, also known as the Manning score. This is done by an ultrasound. On the ultrasound, you will see the fetal movements. You can see gross movements of the baby by the ultrasound. That is very simple. We will also look for fetal tone. What is tone? The baby is obviously, he is sleeping also. Then also there will be some active flexion followed by an active extension sometime of the upper limb or the lower limb. So one active flexion followed by an active extension, this says that the tones of the extensors and the flexors are good. A good tone is always nice for a baby. So fetal breathing movements. Now, like I told you just now, that baby is not breathing inside the uterus, isn't it? We know the baby is breathing through the umbilical cord. He is not having breathing movements because he is oxygenating through the mouth. No, he is not oxygenating that way. He is oxygenating from the umbilicus, but he is swallowing the amniotic fluid. So every time a human like you and me also, when we swallow something, what happens? See, I'm exaggerating by swallowing movements, but it's like our chest will expand. Of course, through my shirt you can't see that so well. So yes, if a baby is swallowing, then the expansion of the chest, that is seen as a breathing movement on the ultrasonography. So if there are breathing movements, there is a good tone and there is good movements and there is adequate non-stress test. That is good. Also amniotic fluid index. So all of these are given 2 points each. NST is done with the NST probe. Along with that, the fetal movement, tone, breathing in, amniotic fluid index is done by the ultrasonography. So this score should be 10 on 10. That is what is a perfect biophysical profile. So now let's see what is the amniotic fluid index. That is also a subject for a lot of MCQs. So if you see the amniotic sac and the fetus in it, then this fetus is surrounded by amniotic fluid. So when the mother is lying down, you put the ultrasound probe in the 4 quadrants, 1, 2, 3 and 4. Suppose this is the head end of the mother and this is the lower end of the mother. Then this amniotic sac will have 4 pockets. So with the ultrasound, you can measure cord-free pockets 1, 2, 3 and 4. And suppose this is 3 centimeters, this is 2 centimeters, this is 3 centimeters and this is 4 centimeters. The vertical depth of these 4 pockets is seen. So this is like 4 plus 3, 7, 10 and 12. In this example, the amniotic fluid index is 12 centimeters, which is normal, isn't it? So the amniotic fluid index is the arithmetic sum of the 4 pockets. Cord-free pockets. All right, the cord should not be in this pocket which I am measuring. So yes, the normal amniotic fluid index is 10 to 15 centimeters, and it is called oligoamnios if it is less than 5 centimeters. It is called polyhydramnios if it is more than 24 centimeters. So we say if it is 25 and more, right? That's easier to remember. Less than 5 is oligo, 25 and more is polyhydramnios. So these are the amniotic fluid index values. But if you want to see the absolute amount of LICA, absolute amount of LICA is 1000 ml, which is supposed to be the normal LICA, and 10 to 15 is the index of that amount of LICA. Less than 500 is oligoamnios and more than 2500 ml is the polyhydramnios. So if you want to see in a single pocket criteria, that is also asked sometimes. if any one pocket is very large or very small. If one pocket is less than equal to 2 centimeters, we know it is oligoamnios, and if one pocket is more than 8 centimeters, that is too much of liquor. So one pocket less than 2 centimeters, I'll take out the equal to, I'm sorry. If it is less than 2 centimeters, any one pocket less than 2 centimeters is oligoamnios, any one pocket more than 8 centimeters is polyhydramnios. Alright, so these are the liquor dynamics. Now, liquor, they'll ask you many questions. Suppose I'll draw the chart of the amniotic fluid in a normal pregnancy. So around 32 weeks to 34 weeks, the liquor is maximum around 1000 ml, and at term, that is at 40 weeks, it is much lesser, it's around 400 to 600 ml only. Suppose there is a pregnancy at 30 weeks or even 28 weeks. At that time, it's a breech. Any patient, XYZ, one patient has at 30 weeks a breech baby. So, what is the management of breech at 30 weeks? Now, we all know that we will do breech vaginal delivery, and it is done in institutional setups. We'll be reading about it also. But yes, I would not want a breech to deliver if I'm given the choice between breech and cephalic delivery. So, suppose this bottle is the baby, and I'm trying to show you this bottle in the abdomen of a mother, and suppose this is the head of the baby and this is the breech of the baby, and at 30 weeks it's a breech. So, I'm looking at the condition that if it is breech, in labor I may have a problem, so might as well hold the baby and turn the baby and make him cephalic. Can we do a version now? You're taking the cephalic part of the baby and turning it through the abdomen and making him now a favorable presentation. So that will not work here because the baby is small at this time, and this small baby, if you turn, he's got a large sac of warm fluid, he's going to turn back. It's like a spa situation for him, isn't it? Warm water, small size, he's going to have a great swimming time. You turn him, he's going to turn back. So at 30 weeks, we do not do versions because yes, what is the most common cause of breech? Prematurity, isn't it? So prematurity will be having breech or oblique or transverse. We are not bothered at this time. At 32 weeks, no. Around 34, 36 weeks, yes, around 36 weeks, the liquor is reduced much more. It's around 600 to 800 ml only now. So around 36 weeks, the liquor is now reducing, the baby is now becoming bigger. So yes, now if the baby is bigger and the liquor is lesser, now you hold the baby. He's got a bigger head, a heavier head at 36 weeks as compared to a 30-week pregnancy, isn't it? So now you hold the head and hold the buttock through the abdominal wall under an ultrasound guidance. You don't do it in the OPD without any ultrasound guidance, alright? So you hold the head and hold the buttocks of the baby and turn the baby in the abdomen and make him cephalic. Now the head is heavier, he is likely to stay in the cephalic position, and liquor is lesser, he is unlikely to go back. Alright, so yes, external cephalic version ECV for a primigravida is done at 36 weeks. For a multigravida is done at 37 weeks. Alright, because the most common cause of breech is the prematurity. So versions, if you do at that time, they are more likely to fail. So after having discussed the biophysical profile, let's move on and see something else. So that's the biophysical profile, and 10 by 10 is a good score. But what about a score which is 8 by 10? I think that's fairly good, and 8 by 10 should be a pass mark easily. So suppose you're my intern and I'm leaving the ward, and I just ask you as a parting question that, okay, fine, how's bed number 7? How's the biophysical profile? You tell me, sir, it is 8 by 10. I'm happy, you are happy. Okay, fine. If there's anything, any problem in the night, you just give me a call, I'm going home. By the way, excuse me, what was the parameter which did not get marks in this patient? Why did you say it was 8 by 10? What was not good? And you tell me, sir, the liquor was less. Everything else is fine. Liquor is less, and if everything else is fine, I'm not bothered about 8 by 10 anymore, because liquor, if you ask me, is the single most important parameter of the biophysical profile, and if that is less, the score is 8 by 10, but that's a false reassurance you're going to get, isn't it? So yes, that's why they made a modified biophysical profile, and that modified biophysical profile is only 2 parameters, that's the amniotic fluid index and the non-stress test. If these 2 are fine, you can continue the pregnancy. A lot of people bank on this. Now, sometimes when you're doing the non-stress test and you put the probe on the mother's tummy, the baby is supposed to move and the fetal heart rate should increase. Now, suppose I've got 7 admissions today, and with 7 admissions I want all of them to have the NST. So I have only around 2 machines and 2 women at a time, and each test should be at least 20-30 minutes to get those 2 accelerations. So I'm going to be very busy, because in addition to that I have a lot of other work in the ward, isn't it? So I put the probe on the mother's tummy 1 and the mother's tummy 2, and I'm waiting for the fetal movements to happen, and the baby is sleeping and the movements don't happen. So wait a minute, non-stress test doesn't mean the baby is bad. The baby could be sleeping. So yes, what do? I go close to the mother and like that, I clap. You got startled, isn't it? So yes, the same way I want the baby to get startled, I make a loud noise like that. That loud noise will startle the baby and the baby wakes up, alright? Sudden movement, and that sudden movement, the heart rate will increase. So yes, a sound stimulation can increase, but that's be very funny that I go in front of pregnant woman and start clapping, isn't it? So yes, there's enough you people make fun of us, isn't? So what we do, we don't have these kind of maneuvers as the approved maneuvers for making the baby wake up. We have a instrument which is going to make loud noise, and that loud noise is complemented with the probe which is kept on the mother's tummy, which is going to give a vibration kind of a stimulus to the tummy. So with the loud noise, there's a vibration given to the abdominal tummy, so the baby moves up and wakes up and moves. So when the baby moves, the heart rate goes up. That's what is known as the vibroacoustic stimulation test. Now the question asked of you people is this part of biophysical profile or is it modified? No, it is not part of biophysical, and it is not definitely part of the modified biophysical profile also. Okay, vibroacoustic stimulation test is just another fetal surveillance test. So another important test after the vibroacoustic stimulation test, and probably one of the most important tests, is the Doppler of the blood vessels. Doppler of the umbilical arteries, the uterine arteries, and also the ductus venosus. So yes, the Doppler of these blood vessels, what do I want to see in this Doppler? In the Doppler, I want to see that they should be always forward flow towards the baby. Like even in your brachial artery, when you see the blood pressure is 120 by 80, isn't it? Because systolic is 120 and the diastolic is 80. But tell me one thing, I know the heart contracts in systole and it is 120. Heart is relaxing in diastole, why should it be 80? And diastolic pressure is 0, isn't it? So why is it 80? Because of the systemic recoil. See, if this is the brachial artery, 120 and recoil 80. So 120, 80. Then that recoil gives pressure and the blood moves forward. So in the fetal blood vessels also, the blood should always move forward, whether it is systole or diastole. Obviously, we know systole is more, diastole is lesser. So yes, let's see the flow patterns which are normal. From the baseline, systolic, diastolic is the normal flow pattern. Now, I'm doing the umbilical artery Doppler and I see systole there is flow, diastole there is a notch. So when there is a diastolic notch, the diastolic notch is the first sign of compromise. The first sign of compromise in the fetal flow is the diastolic notching. The diastolic notch tells us that some things are now getting worse. Systolic flow, but no diastolic flow. This is known as the absent diastolic flow. This is suggestive of severe compromise. Now I increase my surveillance. I increase my surveillance more regularly, and I am already telling the mother that I may have to do an intervention very soon. Now, there's another pattern which is still more ominous. Systole, diastole. Systole, diastole. With the diastole, there is no flow to the baby. In fact, it is coming out of the baby. There is so much of resistance that there is diastolic reversal of flow. So that's what I was trying to tell you when I was giving the example of the brachial artery. There is always forward flow in an organ. Systolic more, diastolic less, but towards the organ. Now there is flow towards the baby, but outside the baby in diastole. So this is known as the reversal diastolic flow. Reversal of diastolic flow. Reversal means only one thing. It means imminent death. Imminent death of the fetus is what is going to happen. So yes, time to terminate the pregnancy. That is what is the meaning of this reversal of diastolic flow. So they've asked you this Doppler based question so many times, and which is the most important Doppler which will give us the assessment of the perfusion or the uteroplacental flow. Uterine artery Doppler is good, but the umbilical artery Doppler is better. But you know what has come as the question for you people in the last two exams? Which of the following flow patterns done by the Doppler assessment will best signify perfusion to the baby? Ductus venosus flow patterns. Alright, the ductus venosus flow patterns, that M wave which is formed in the ductus venosus, that wave is seen, we know the baby is fine. If that is not seen, then we know there is a compromise. So single best measure, yes, that has already come in your exam once. Single best measure to assess the flow is actually the ductus venosus flow. But if they have not given you the choice, because still it is quite a recent addition to the list of things, if they are not giving you the choice, go with the umbilical artery Doppler. Alright, so we have now seen that a patient is having a IUGR process, and with the IUGR process, I have continued the pregnancy, let's say from the 32 weeks, there was a small baby of 28 week size only, so I've continued till 33 weeks with my surveillance. Now I've come to 34 weeks. 34 weeks is very nice because the lung has got mature, and I'm continuing the surveillance. At 35 weeks, I see that the NST is not so reactive now. You know, we have to actually do the biophysical very repeatedly, and I see that the Liker is now coming in the low normal. It is not 10 to 15, it is coming around 8, 9. Although it is not less than 5, it is not frank oligohydramnios, but it's a low normal. So I'm now getting a little worried that I think it's around 35.5 weeks. Let me do a delivery now. I've already achieved lung maturity, I've already achieved some size, so might as well take the baby out. So what is the management of IUGR? Apart from the surveillance, what is next? Why just IUGR, PIH or gestation diabetes mellitus? This surveillance topic, I'm not talking only about IUGR, I've told you already, I'm talking about surveillance in general. So what is the management of IUGR, for example, when the baby has reached around 35.5 weeks and there is some compromise in the surveillance parameters? What do? You do normal delivery or you do a cesarean? So yes, now that's the other next important fundamental in obstetrics. I will always do normal delivery. There is no choice, there is no discussion. Normal hi karna hai. I will always do normal delivery. Now, not at any cost. I am not saying that. I will always try to do a normal delivery, but not at any cost. That I am not saying. I will do normal delivery as far as possible because that is what is obstetrics. But yes, I know that if there is a compromise and I am foolhardy and I am doing a normal delivery at any cost, I may lose a baby. So yes, what tells me that I can give her the choice of normal delivery and I can safely give her that normal delivery contractions and so many strong contractions? Yes, in the antepartum surveillance only, we have one test like that, and that is the contraction stress test, also known as the oxytocin stimulation test. So yes, patient is not in labor, mind you, it is 35.5 weeks and I know there is some compromise. So what do? I give her some IV oxytocin. I give IV oxytocin till I enlisted 2 or 3 contractions, and I see with the contraction, I put a probe on the tummy of the mother to see the heart rate, and with a contraction I see the heart rate plummets. Another contraction, it plummets again. Now 1 or 2 contractions, she's not in active labor. Just 1 or 2 contractions, the heart rate is plummeting. This baby cannot tolerate normal labor. Do a cesarean section. In other conditions, I've given contraction and the heart rate is going fine. We can give a trial of normal vaginal delivery. So yes, the contraction stress test or the oxytocin stimulation test tells us the plausibility of doing a normal labor, the chances that your normal labor will succeed.